TopMedTalk.
Welcome to TopMedTalk. Today's TopMedTalk, Screening and Assessment for Prehabilitation, a panel discussion, is taken from the World Congress of Prehabilitation. It's chaired by Franco Carli, Professor of Anesthesia at McGill University and Associate Professor in the School of Dietetics and Human Nutrition at McGill University, with panelists Sandy Jack, Professor of Prehabilitation Medicine in Clinical and Experimental Sciences from the Faculty of Medicine at the University of Southampton, Chelsia Gillis, Assistant Professor in the School of Human Nutrition in the Faculty of Agricultural and Environmental Sciences at McGill University, Raquel Sebio García, a physiotherapist and clinical researcher at the hospital clinic in Barcelona, Spain, Carol Keane, consultant AHP, physiotherapist at Sheffield Teaching Hospitals NHS Foundation Trust, and Lee Ingle, Professor in Sport, Health and Exercise Science at the University of Hull. Don't forget, of course, the conversations which preceded this Q&A panel are available in your TopMedTalk timeline. You can either scroll down and find them or click on the show notes and you'll find links to them all there.
Right, so I will invite now Sandy, Chelsia, Raquel, and Carol and Lee. Now, I like very much one thing that I really enjoy, Carol, is that she mentioned this idea of support from the psychological aspect when you actually do exercise, which I think is very good because then you're training your team as well, right? Which is very important. So he is not really too selective. I do my job and the other do the job. But there is very much intercollegiality with this one. So this is maybe you want to elaborate at some stage. What are the tricks that we can use it to train your staff and also have this support system? Maybe you want to comment on that before we start and people write questions.
Yeah, I can talk about that. So we're an MDT multimodal prehabilitation service. And, in our costing, we have funding for psychological support. But like everybody, it's really hard to get it. So although we've been up and running for a year, we've only just appointed 1 day a week of a clinical psychologist to work within our service, and they will start in September. So it really has been about what can we do as well as that or instead of that. But our clinical psychology department have been really, really supportive of what we're doing and want to be part of it. So it's them who've helped us to design our intervention, who've helped us to put together our workshops and our preparation, and who've helped us to train our staff. So level 2 psychological care is available, or most of the cancer nurse specialists in the UK are trained to that level. And we've simply said that that's going to be the case for our staff as well. And so it's come from our clinical psychology team, and we've kind of used the funding, if you like, that we should be paying to a psychologist to help the psychology team to get us up and going, to get us up and running, and to spread that knowledge across the base of the team. And I think that's been really, really valuable. And I think the whole team has felt it. Definitely all of our patients have felt it. It's a whole team intervention. So all of our team are trained in motivational and interviewing as well. And that goes to our admin as well as our fitness instructors, our dietitians, our physios. So that every time anyone answers the phone, those first phone calls that we make where we invite people to come in and be part of the service and come for their first assessment, those staff delivering those conversations have all got good listening skills, are all trained in motivational interviewing, are all able to have a supportive conversation. So right from the very beginning, that psychological well-being, feeling and the behaviour change starts right from that very first phone call and is embedded in everything and every conversation that we have and that we do. Or that's the hope, that's the intention. So it's all part of everything that we do or request the service.
Any comment, any suggestion, any activity? Sandy, you have some experience on that?
Yeah, so 3 excellent talks, thank you. Really important comment, Carol, about that, because we already know that clinical nurse specialists also deliver some level of psychological and emotional support. I'm going to throw it out there to Professor Grocart and June Davis that when we write the guidance or guidelines, I think this is really important that we start thinking more about the who that we touched on in our 2019. But it's a great point if everybody has the same messaging. and we can support patients through the distress, because distress is huge. It's just all about that support. So I absolutely think that that's the way we should do this.
Great. Let's have a look. There are some interesting questions. I think there is one really, I don't know whether that fits here, but why not? I note that no one includes screening for cognitive impairment. Now, this is a big elephant in the room in aging surgical patients with delirium risk. I think we are all aware that this is an issue, that's why we need probably geriatricians here to help us. Any comment, a brief comment on that? Because I'm sure that probably you realize that it may be difficult sometimes to deal with this patient from the point of view of adherence to nutrition, or to they don't want to do a testing, or they're confused, and prediction obviously of delirium postoperative cognition.
Yeah, in our initial assessment, it's a question that we ask. We ask patients if they've noticed any changes. Often there's a family member in that assessment, and we would open that question to the floor and we would try and have that conversation. In our service, and everywhere is different, where that comes up, it comes into individualised and personalised care, I think. So although somebody may have some memory problems, or there may be some cognitive impairments there, we're supporting a young man through our service who's got learning difficulties from a head injury that he's had in the past. And it's simply then been about identifying what his level of ability is, where he struggles, and finding the right tools to support. Somebody talked earlier, didn't they, about motivation, and some people need more help than others. And this touches into health inequalities and those things. So we don't screen, we ask, and where we identify it, we would then hone in and personalise what we're offering to that patient. So they're certainly not somebody you'd send away with a leaflet. They might be somebody who you might bring for a couple of one-to-one sessions before they join a group. You would rely less on them exercising at home on their own and being more likely to be part of a peer support, or you might see which family members are available to help them to do their exercises at home with them, or to help who's cooking their food, who's doing their shopping. So back to individualised and personalised care on that one.
Yes, I would like to comment on the role of the caregiver here, because I think it's very important. We don't assess usually at our service cognitive impairment as like a part of the program. We do that for some of the studies that we undergoing. But as a regular assessment, we don't usually do that, although it's a thing that you easily detect on the consultation with, for example, the surgeon or the anesthesiologist at the beginning. So I think it's very important to identify it, because yes, you can take in on the role of the caregiver at home, that the person that, is he or she living alone? Is she having some help from maybe social service or whatever? And you can have these people on board to help going through the program without any difficulties, or maybe some of the difficulties that they will experience if they were living at home alone, for example. So I think, having the caregiver, and we usually have them always at the consultation with us while we do the motivational interview and everything, and while we explain the program. So having them on board is very, very important for them and for us as well, for the success of the program.
Well, I think there's another question here. Is there educational resource which will allow our prehab practitioner to offer psychological support?
I think as health professionals, we as you said, we have a basic health literacy. People coming through who've trained as a physio, who've trained as a dietitian, who've worked in healthcare, who've worked with cancer patients for a long time, have that knowledge and understanding of the impact. As Sandy said, top quality nursing does this day in and day out. So within the MDT, there is a huge level of skill already. And I would say that the training that our team went through was very much about saying, what do you know already? Well, actually, do you know what? It's loads. You know loads and loads of this already. And here are a few extra things that you need to know on top of it. So certainly not starting from scratch within health teams. Depending on the professional groups that you've got in there, there can be a lot of learning from each other, can't there? About who's the right person to have that conversation, who's got that skills, who's got that experience, having that background of support. So yeah, I think it's less about being prescriptive and more about recognising what we already know and where we can build a mixture of experience, knowledge and a good team around us to up everybody's skills across the board.
Do you think there is a value for a nurse in this context, dealing with the patient, nurse with the psychosocial training? We know in cancer it is quite common, where it could actually help and be part of the team. At the moment, we've been really segregating ourselves to the classical exercise, nutrition, psychology. But you think the nursing has got a much more sort of global assessment, global idea of interacting the three and supporting the patient also liaison with the community. We should really think about the figure of a person. Would you agree? We think we should have in the future a nursing role or in the prehabilitation.
Hugely, Franco. I really think that nurses are key. They are the continuum of care, particularly in patients with cancer. They have got skill set to be able to support patients emotionally. I'm not sure whether we call it psychological. Understand their physical activity, understand their needs, understand the pathway, understand their toxicities. So for me, as we have in Southampton, there's Denny and I, our service, it's nurse-led. Because patients understand and trust nurses. I'm not saying they don't trust other professionals, but they're the continuum of care. I also think that we need to look at education and some standards around this. So the new Clinical Exercise Physiologist UK curriculum framework does actually upskill exercise physiologists to be able to deliver emotional care. They don't call it psychological because we all have to stay within our lane. Healthy eating, not nutrition, and obviously their expertise in exercise. So I know there's a lot of work nationally going on with health education in England, but this is a great opportunity to learn from good practice in Sheffield and to also embrace the nurses as professionals that are key to prehabilitation, in my humble opinion.
Let's go to another question. How do we fully assess or do full screen patient in our complex multimodal services while do avoiding questionnaire outcome measure fatigue, which is a problem? So any ideas, any contribution? We should avoid all this. My view sometimes is that really we're working at focusing on consultation. And that's probably one of the questions. You send it to the dietetic department, send it to the physiotherapy department of the psychology. Then you have a really separate return back of the consultation. I think here probably means that fully screened patient in a complex multimodal service, that means you put together and then you discuss. What is your opinion on that? From your different experience here. Chelsia, you want to comment?
I think it's very real that there is questionnaire fatigue with our patients for sure. And I think that the first thing you need to do is slim down your questionnaires. You need to make sure you're only using the questionnaires that are really, really important and will add to the service or add to your outcomes. So at the beginning, if the screen is to later have an assessment or to decide what the intervention might be, maybe putting those up front before the patient has too much fatigue, and any of your outcome questionnaires at the end might be a better idea, because those are vital, those screening questionnaires, to identify the right services the patient needs. And I think it really matters how you deliver it. As I mentioned with the script, it's really important to get the truth out of people. And you'll have some people when they're with the patient, they're what I call a checklist person. And they just go through, have you lost weight? Have you done this? Patients don't respond well to that. So I guess having the right person do the screening is also really important. It becomes a conversation instead of just a checklist.
Yeah, good point. Raquel.
I was going to say that I totally agree. We are overwhelming patients with questionnaires. Sometimes they are not even that necessary because you don't get the information that you are really need in order to conduct your program. So let's just start by, selecting the questionnaires that we need instead of just burden the patients with hundreds of them. And I think another thing that is very important here is that patients might not feel so overwhelmed if they are getting some feedback from the questionnaires. Because sometimes what they tell us is, look, I'm just answering these 40 questions or 50 questions, and I don't know what they are for. I don't know if I am getting anything in return from this. So maybe if we explain them, this is for you to understand, or this is for us to understand, how are you going to deal with this and this and that? And we are going to adapt the intervention based on this. So just having the conversation that Chelsia was saying, I think it's more useful just to hand them 10 or 15 questions or whatever the amount you have and just say, fill this out. That doesn't make any sense.
So in a way, Lee, you will be, because it's a physical assessment, physical functional capacity and so on, what would you recommend if question like that, where you prefer to actually see physically the patient and see how they are? Are they coming in a wheelchair? They're not coming in a wheelchair. They're coming with a cane. What can you do? We're probably better than the DASI to some extent.
Yeah, I think it's obviously Depends on the speciality. So what's the particular issue with the patient? So obviously a patient with cardiovascular disease, you're going to treat them very different from a patient who's got orthopedic limitations. So it's very much comes down to, the type of patient that you have. It's about personalisation, individuality in terms of the assessments. I'm not going to give you an answer and say you should do this, because there is no perfect answer. There are a range of tools out there, and I think you need to identify the right tool for the right patient.
I mean, we know that we ask the patient to stay 2-3 hours with us. We tell them in advance that's you're going to stay, you bring your shoes, you bring whatever, comfortable and so on. So I think people are expecting. The expectation, it's all about expectation, what is expected. And through an interview or screening or the phone may help for the patient to understand why they're coming and so on. So that could facilitate. Now, what is your view of a questionnaire through the email? How would you trust an email questionnaire through the email? Sometimes because comprehension. And whether at the same time you don't want to manipulate the patient. So in your experience with the intervention, does the example, there are some questions that really are not clear. And the same for nutrition and the same for psychological. I mean, the GAD-7 and the HADS. What is your view of how do you trust?
I can just say that anytime I see work published from people who do that, I'm always surprised at how the level of malnutrition is so low. So it says to me right there that they're not capturing everybody, but I think that if that's the tool that you have available, at least you're capturing some people. So I guess there's the ideal world, and then there's what's possible. So if you only have the resources to do email or telephone, you will probably miss patients, but at least you have seen patients.
We try and get patients to complete some questionnaires before they come in. And then we have that conversation with them when they're in, where we go through their responses and make that relevant and applicable to what we're going to do with treatment. So we email them a link to a form that they can fill out to complete their questionnaires. And loads of them don't. And it's not that they won't, it's that they can't. It's that they haven't got internet access, they don't understand it. So we then have to back that. If we want that information and it's important, which it is, we have to back that up. And we're still learning. We've tried so many different ways to make this happen and make it right. We've tried phoning them to remind them, texting them to remind them. We sometimes do it over the phone with patients. That's quite a tricky phone call. We invite them to come in half an hour earlier for their appointment so we can go through it with them. It is an absolute minefield. And then that leads you, if I'm really honest, leads you questioning the value of the data you're capturing. If it's this hard to get it, we really have to be doing something with it that's important, because we're spending a lot of clinician time and a lot of patient time and a lot of carer time capturing that information. So we have to be doing something really, really, really important with it to make it worthwhile. Or, as you say, ask less questions as well. Really hard balance in clinical practice.
I think the converse of that, though, is certainly where I live, which is a particularly rural area. If we didn't email or send people the questionnaires, we'd get no data at all. So there's that fine balance around, if you want some data, is some data better than no data? And in most cases, it probably is.
Okay, so is there any theoretical benefit to carb loading pre-surgery to provide the body with a readily available glucose and hopefully avoid muscular catabolism?
So that's enhanced recovery after surgery. That's the ARAS protocol. There is carb loading in the ARAS protocol. And they certainly publish studies that show that there is an earlier attainment of whole body protein balance with the carb loading.
Still controversial, but, still increasing insulin sensitivity. We know that. That's a good thing.
Well, it's controversial in terms of length of stay and things like that, but physiologically, the data's there.
Yeah, that's the thing. Okay, well, whey protein. What about immunonutrition? Chelsea again.
The key here is that you need to prescribe based on your screening and assessment. So you're assessing the patient, and that comprehensive dietitian assessment, the dietitian examines what the patient eats and then decides if the patient needs supplementation. Some patients don't need any supplementation. Sometimes if we have enough time before surgery, we'll even allow the patient a week to kind of manage it with their food alone and see if they can increase their needs, to increase their food intake to meet their needs. And if they can't, then we will prescribe supplements. So it's not a one-size-fits-all prescription. It's really individualized based on the patient's needs. And if you look at their food recall, their 24-hour food recall, and you see that this patient needs to meet 40 grams of protein to meet their needs every single day, how are they going to do that? That's a conversation you have with the patient, but through food and supplements.
I think immune nutrition has been shown to be useful especially in type of surgery where the risk of infection is very high. So, more specifically.
It's the omega-3s in particular with the immunonutrition that's beneficial.
Lee, can you discuss more about why CPET is falling out of favor as a screening tool?
I would say the CPET has never been in favour, certainly in the UK. That's my honest truth. I mean, I've been working in this field for 25 years, and even 25 years ago, it wasn't very popular. I mean, there are some obvious issues. I mean, initially, the cost of a metabolic cart is in excess of £10,000. And also, you need staff who have the training to interpret the data. There's a mind-boggling array of variables from CPET. And just interpreting the Wasserman 9-panel plot, for those of you familiar with it, you need a degree in physics. So there's a huge amount of training that goes into being able to interpret CPET data. And it comes often down to time and money. People don't have the time, and the systems and the training that's required are often too expensive.
Sandy.
So CPET's an assessment tool, let's make that clear. And we know there are other tools out there, but they're not tried and tested. So I think that it's not that it's losing favour. It is still the gold standard, particularly in pre-surgical patients. But we need better screening tools so that then we assess the patients that actually fail their screening. And that's what we haven't really got yet, although I think DASI is a prime candidate to be that. I think there's a question from Helen in the audience.
Hi, Helen Anderson here from Plymouth. It was just to add on, I think that we know from our series of questionnaires that have been sent around by POEX that there is increasing coverage of CPET within the UK and availability to teens, along with the training that goes alongside with that. So actually, I think that things have changed considerably over the last 20 years. There is far more insight and understanding of how it can be used. And I think it's to go back to, this is an assessment tool, and it gives us huge amounts of valuable data about patients' other comorbidities and a diagnostic tool. So I think there is huge benefit in it, and it isn't a screening tool. It's to give us more information and assessment, and that it's not just the answer in a single number to what our patients need. So I think it's more complex.
Yes, actually, I was going to comment before on that. As a physiotherapist who prescribed the training, for me, CPET is not only about assessment. I would love all my patients to have a CPET because, of course, that will mean that the way that I will approach my training will be totally different. I will have all the elements necessary to provide the best treatment or the best training possible. But I do understand the trickiest part of the CPET, that is not so easy to perform. You definitely need the personnel, and you definitely need the training and the time. So we need this screening, as you have in nutrition, to tell us in whose patient should we do in this CPET assessment, in whom we should invest 1 hour of our time, because it's about that time, to do the test and actually do the assessment. But I do believe that the information that we get from CPET is, at this point, I mean, there's no other test that can provide as much information as that. So we need to take that into consideration as well.
Somebody else? Yes, Anthony.
Yeah, I just wanted to add into that. I agree with Helen. In perioperative services in the UK, more than 50% of trusts have access to CPET currently. And I think it's really important, as the last two speakers have said, it's not a screening tool. It is an assessment tool. But somebody asked earlier about the lowest 25 percentile. And one of the massive benefits of CPET compared to doing a 6-minute walk test, just asking some questions, is that you have some safety information, as well as then some targets which are individualized for the patient to be able to prescribe a prehab program. So that is its benefit. It's not about a number that tells you about the patient's risk. It puts people into, all categories at risk. But if you are going to do a supervised, individualized exercise program, you need to tailor it to something. And that's where it's been helpful. And as we've transitioned, so our prehab service in Southampton, which is multimodal and community-based in gyms, we use Darcy to screen, and we CPET people. We've adjusted the Darcy equation. So if the VO2 peak is under 15, then we CPET them. And that's been really helpful to some people are safe if you're going to then send them to that. We have patients trained by exercise trainers, exercise professionals in community gyms. But having taken a patient to a VO2 peak in a supervised way, that makes you much more comfortable with the safety of them training remotely in the community, because that is one of the issues when we're looking at the bottom 25%. And certainly we are taking on board for the gyms that risk, saying they're fit to exercise. So the patient with moderate aortic stenosis, for example, or with heart failure, or with atrial fibrillation, it is very reassuring to put them through a maximum CPET test. I feel very comfortable sending them for an exercise program. So it has different uses that aren't all to do with risk.
Do you want to comment?
Hi, Gabriele Baldini, University of Florence. I would like to ask, how would you interpret the result of the METS trial with the recently published trial from the Swiss group Basel, who gave different interpretations, although different population, different frequency of outcome, primary outcomes, about the subjective assessment with the METS lesson for like METS trial, basically no value, no indication about functional capacity, no predictive value, versus the recently published trial that seems to give value in predicting major cardiovascular events. What's your take-home message? Because how would you interpret a patient who tells you, I can climb 2 flights of stairs?
Yeah, so the METS trial, did you say? So
yeah.
The one published in The Lancet 4 or 5 years ago.
Yeah.
That's actually the biggest trial to date. So when we look at systematic reviews, that's the one that's probably got the biggest influence. So we tend to take what that says probably as being more influential than perhaps some of the other smaller trials that are out there. So to me, that's the most significant trial in this sphere, in the sort of perioperative sphere at the moment. There are other trials that are about to report, which hopefully will add to the data that's already out there from the METS trial. But it's probably the most influential at this stage, so people tend to listen to it and act on it.
All right, any other comment on that?
Dr. Carli?
Yes.
Tilio Barbado from Duke University in the United States. Great session. I noticed working with different disciplines that the anesthesiologists seem to focus more on the oxygen delivery and supply demand mismatch that occurs like early in surgery and in the ICU in the first day post-op, and physical therapy and other disciplines focus more on the delayed functional recovery after surgery, the balance, the physical strength, the ability to participate in rehabilitation. And so I wonder if we are, combining or talking about different things, maybe related, but different things when we talk about assessing for physical function, with CPET assessing more of the cardiorespiratory fitness and the oxygen delivery consumption part of the equation, and DASI and gait speed and the walk tests assessing things that are more global, that have to do with balance and physical strength and even, depression and, visual acuity and things like that. So are they the same or are they different? Should we talking about them in different ways?
I think we are dealing with one is an assessment that CPET is very particular in a way that, in my view, is only an assessment, as was said before. But, when you're talking about, depends on the patient you have, too, in my view. You have a patient really need concentrated very much on muscle strength, and then you evaluate muscle strength because it's poor muscle strength or limited. Or you have a patient who have I would say, unable to perform because their endurance is low. So I think really that's where the precision comes too, in a way. Precision medicine comes in. So I don't think one fits all. But in some measurement, we don't have a composite. That's the question. Really, some of you can suggest that, complement this discussion. I think a composite would be very useful to have a composite of type, quality, of functional strength altogether. And that's where I don't think we have at the moment. It's only the clinical assessment that we have. I see some, Jerry?
Hi, Jerry Donahue from UK. I wonder, we're talking a lot about CPET and we're focusing on 2 or 3 variables, Lee, which we've used over time. Do you have any comment on how artificial intelligence might redefine the way we assess patients in the very near future? There are trials underway, people looking at data using AI platforms. And there must be a huge amount of data there that we're not even using or looking at in a structured way. Do you have any thoughts about how exciting that could be?
It's a fascinating area, I think, artificial intelligence. I think it's obviously an area for the future and an area for now. I think if we can synthesize these huge data sets that we've got, I think there's ways of looking at, I mentioned in my presentation this morning, there is no single predictor or discriminator of risk, but there might be 4 or 5 that we can use in a composite score, for example. So we could use the power of AI to help us develop those composite scores. And that's actually a project that I'm working on at the moment, but I think it's definitely a project that needs to be done.
Okay, so I think we change because there are 2 interesting questions that were like, what's sarcopenia assessment to be recommended in prehab setting? That's for Chelsia.
For sarcopenia, if you're working with cancer patients, they should have the abdominal CT scans. That's really the gold standard for identifying sarcopenia because you can do muscle quantity and quality. So if you have those abdominal CT scans, I would recommend that. And if you don't have those abdominal CT scans, you could use something like bioelectrical impedance, and that indirectly measures fat-free mass. So it's not the best measurement because it's indirect, but that's about a $10,000 piece of equipment. And then if you don't have that, the SARC-CAF I mentioned, that's a screening tool that you can use. So it's a couple questions and then you measure their circumference of their calf. So those are some options you can use.
Linda, you want to comment?
Thanks. Now they're using AI to read those CT L3 muscle mass in CT. So that's a really good use of AI that we were just talking about. My question was around, we've just implemented some prehab across different hospitals and the ERAS nurse is doing the screening for where, what sort of individualised areas patients might need to have in head and neck cancer and different cancers, perhaps. And I was wondering, Carol, you hadn't mentioned, we're using the PQ4, the 4, not the PQH4, not the 7, as a screening tool. You haven't mentioned that because it's just 4 questions. So Chelsia mentioned the short PGSGA. We're actually using the MST for a screen, but really because of fatigue and time in the clinic, really we're using 3 screening tools, PHQ4, the MST and the Darcy. And they don't take very long, but they can't take very long because there's no time in the clinics. And I just wondered if you had any experience with that, Carol.
Not with the briefer PHQ. No, we use the PHQ-9, and I think it goes to, again, what other people have said. It's where you're using it, when you're using it, and why you're using it. So we are fortunate to get universal referrals into our service, so clinicians will refer everybody from clinics. So we're not necessarily screening in or out, and I think those brief screening tools are really helpful to do that. Once our patients land with us, we're looking to screen for level of risk, and so that allows us to use the more extensive tools. So, there's a really good conversation here, isn't there, for future about screening versus assessment and their place and point and when you might use one versus the other. So I think that's what we've touched on really there, isn't it?
Great. I think we have one. I think that's a very good question, which is measure functional capacity to capture frailty in increasing elderly surgical population, which is true. Okay, let's have an answer from each of you. Raquel, you want to start?
I don't think they do fully. I think they might help. I was going to say like a screening, but it's not a specific screening. But of course, if someone is frail and you do a CPET or you do a 6-minute walking test, you're going to see some repercussion on the frailty on the test. But I don't think you're going to capture the extent of the frailty of the patient with those tests. So I think you need to add something on top of that, like a screening specific tool for frailty or maybe some measures of muscle function as well, to actually get the idea of whether the patient is frail or not. And this is just our opinion based on clinical practice.
Sandy?
I agree, but Linda Denny's an absolute expert in cachexia, which we haven't touched on, so I wondered whether I might just throw that back to Linda. I completely agree. I think it's a very complex disease.
Well, definitely we know that the FREED includes also functional capacity, while the Rockwood does a global assessment, which is more sort of behavioral and so on. So I think that's if you decide to capture frailty in terms of functional capacity, I think probably the FREED will be probably more accurate to that respect.
Yeah, I think to actually assess it correctly, it should be by a professional who understands the constructs of frailty. So probably a geriatrician, but also picking up cachexia and the complexity around the different levels of cachexia, I think is really important. And I'm not sure we have a tool that will accurately do that at the moment. So I don't know whether
Frailty is also one of those things we don't have a single definition for. So you can look at the phenotype, which is the FREED definition, or you can, like you mentioned, there's different types of tools depending on the definition of frailty. And I just wanted to mention that the frail study that we did we had the FREED phenotype, our frailty assessment, and we used the 6-minute walk test, and then we compared the two, and they weren't the same at all. They didn't correlate well.
John.
What they said, plus, just really to highlight that quite a lot of the frailty tools and assessments are validated in elderly populations, and in cancer we have a lot of young, frail patients. And so we have to question whether those, so for example, in head and neck, and so we have to question whether the tools that we're using are the right things for the populations that we've got.
I'll just throw a couple of tests into the mix. Hand grip dynamometry is often used to look at frailty, and also the timed up and go, which is a functional test, is also often used in frailty assessment.
Well, I think you agree that maybe we should use you should have a geriatrician to do a frailty test from the global point of view, cognitive. I think we stop, Danny. There you go, it's fine.
Well done, everybody.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.